Hi, everyone. My name is Dr. Robert Groysman, and this is our live question and answer on long COVID. Just a reminder, I can't diagnose or come up with treatments for you in a public forum such as this. If that's something you need, then just reach out to my office and we'll be glad to help you. Amira, unfortunately, won't be joining us today. She's got some kind of stomach bug and is not available. But I'll see what I can do on my own here. And for those of you who know me, know that I treat long COVID and COVID vaccine related injury, as well as chronic fatigue syndrome, POTS, Mcast, and several other related conditions. And I've been doing that since the start of long COVID back in 2020. What I wanted to go over today was a correspondence that was published in The Lancet, which is a fairly prominent journal, talking about the persistence of the antigen after COVID, or what they call the post-acute um, COVID period. Welcome, welcome. And of course, I'll take questions as they come in. But I wanted to bring up this study because this is kind of the first interesting study that we're looking at. And pardon me, because they changed the system from the streaming service I use, which is called Restream, and it's very different than what I'm used to. So this is the study. It's from Lancet, and what's important about this study is it looks at antigen persistence post-COVID, and I'll quickly summarize it. They looked at 171 adults who had COVID, and they took 61 specimens from 42 of those participants. So basically 25% of the group. And they had a control group, which was 250 adults that had blood samples donated prior to COVID-19. And what they found was several different antigens, not just antibodies. Now, most tests these days that we see are measuring antibodies, but what we're interested in is actually looking at the antigen. So something something is producing the antigen, which is I guess you can call it a toxin or something that our body is reacting to, or our immune system is reacting to. And what they found, and let me see if I can get this to work. So compared to this pre-pandemic antigen, which would be fairly low from their blood, they found that at the 3-6 months it was relatively high, and then it progressively decreased. And this covers all antigens. And then they split it up by spike antigen, which everybody's familiar with, and also the nucleocapsid antigen, which is listed here. Okay, but the good news is what I'm seeing is that it's going down as time goes on. So what does this mean? Does this mean that the antigen is causing long COVID? Well, the answer is we don't know. All we know is that there's still an antigen being produced or being retained by the body. But what it's actually doing is we don't know. And that's kind of what I wanted to say about this study, okay? So let's take a look and see if we have any questions. So, and just to state that I don't own any part of the Lancet, or I don't have copyright from the Lancet or the authors. This has just been displayed for educational purposes. Okay, wow. Okay, so we got already into questions. So let's take a look. A Facebook user is asking about any other ideas until therapy is available. Well, yes, I mean, there's still many ideas that are out there, and I still split things up into dysautonomia, mitochondrial dysfunction, gut dysbiosis, and Mcast or histamine intolerance. And I believe all of these contribute to long COVID in some way. So not everybody is primarily have long COVID from dysautonomia. However, I believe it is the primary mechanism that we're seeing. And while you can treat the others, it mostly relies on treating the dysautonomia first. Okay. Let me see what the next question is. So, wow, we're having them coming in quickly here. Give me one moment to see what is popping up next here. So dichloroacetate is the medication I use for mitochondrial dysfunction. It is prescription in some areas where it's over the counter in others. So I can't tell you where to purchase it unless I know where you are. And that's for Doherty KR and Andre. Any ideas on parosmia? She is asking. Let me see here how I can get this to work. There we go. Like I said, they changed the whole system around. Now that I was finally used to it, they're making changes to this restream service that makes it a little confusing for me. So I don't see parosmia as often in the last 6 to 8 months. I still think treatment with a stellate ganglion procedure and vagus nerve stimulation is the best way to approach something like this. However, if you've tried this or it has not worked for you, there is some evidence that the nicotine patch can help, at least for some. And there's some other kind of obscure treatments such as theophylline, nasal spray or nasal wash. That's been successful for some for anosmia, not for parosmia. There's insulin that can be basically nebulized to into the nasal cavity, not orally. That's been shown to help some. And the last would be like oxytocin, nasal spray, has helped some. But most of these have helped with anosmia more so than parosmia. Okay, but that's all we have for right now. And as I said, especially with the nasal stuff and the taste, such as the anosmias, the parosmias, the dysgeusias, the agusias, those tend to become more resistant with time. So the longer you've had it, the more difficult it is to get that resolved. It's not as much so for other symptoms, but in particular those two, they tend to be more resistant as time goes on. I hope that answers your question, Andrea. Next question is coming from Chris. And he is asking about a relationship between chronic fatigue syndrome and sleep apnea. Does treating sleep apnea with CPAP aid in mitochondrial repair? Well, there's several different causes of sleep apnea. The most common type that we see is what's called an obstructive sleep apnea. And that means that there's an obstruction to the flow either at the nose or at the throat area, so that you're no longer able to exchange air, and that wakes you up. So I'm not really sure kind of where you're going with the question, Chris, regarding a relationship between chronic fatigue syndrome and sleep apnea. I mean, obviously, chronic fatigue syndrome does mess with sleep and causes insomnia and things like that. So to answer your question is, I'm not sure if treating sleep apnea would cause mitochondrial repair, but it would probably allow for generalized body repair, because if you're not getting good sleep, if you're not getting deep sleep, then you're not healing, you're not repairing. So in a general sense, I believe that that would be the case. I hope that answers your question, Chris. We have a question from, I'm not sure. So we don't know what the cause of Mcast is. Okay. We know that it's inappropriate degranulation of mast cells. And yes, they release histamine, but they also release a lot of other things that are inside mast cells, including digestive enzymes, including proteases. But what exactly causes this inappropriate discharge? We don't know. We just don't know. So it is occurring more frequently with long COVID, and it is probably related to the immune system dysregulation. But as to the actual cause, we don't know. Lee Lewis, or Lee, I guess, is asking, could we have gotten the antigen from both either COVID and the vaccine? So from the vaccine, the only antigen you can get would be the spike protein antigen. And whether it comes from a vaccine manufacturer that actually introduces the antigen directly as a protein, or one that has the mRNA to encode or produce when it gets into your cells, basically the antigen, it would only be the spike protein or fragment of the spike protein. It wouldn't be the nucleocapsid or any other part of the virus. And just to reiterate, it's not alive. The spike antigen is not alive. It has no capacity to reproduce or cause virulence. In other words, it has no way of making somebody else sick. However, that is the only antigen you can get from the vaccine, whereas the virus can cause several different antigens. And as this latest correspondence showed, the top two measured would be the nucleocapsid and the spike protein. Okay. So this is a question coming from a Facebook user, and talking about last symptom being fatigue, and what treatments do I find that work with post-viral fatigue. So my approach to treatment is not symptom-based, it's cause-based. And I try to attack the causes of long COVID or related symptoms. However, if you've tried most of the treatments and you're still left with a straggling symptom like fatigue, I would look towards the CFS ME line of treatments that have been successful. And one of them would be low dose naltrexone. Another would be guanfacine. Some people have had success with my brain is not picking up on this last one that I'm thinking of. It'll come to me. And I'll come back to the question, okay? Things like intermittent fasting have also been helpful with fatigue as well. Mestinon, pyridostigmine, is also sometimes helpful for chronic fatigue. Brandy is asking, can EAT, which stands for epipharyngeal abrasive therapy, and SGB, which normally stands for stellate ganglion block, but I refer to it as a stellate ganglion procedure because what I do is different from other docs, can be done in the same visit. And yes, they can. They can be done on the same visit on the same day. Thanks, Brandy. So before I go on to the next question, I have a couple announcements to make. Actually, hold on. Let me take this off for a second. And I'm going to bring up a couple of things. So this was supposed to be by myself and Amira. We usually do these together. But as I said, she has a bug and she's not feeling well today. Feel better, Amira. I wanted to give both of our websites so you guys have them. You can find just about everything on covidinstitute.org and her website, longcovidassociation.com. And one interesting thing that Meta, the organization that owns Facebook, has decided to do, and they decided to stop third-party app streaming, which is what I do. So I'm able to stream not just to Facebook group, but also to the page and to YouTube and to Twitter, now known as X, and to LinkedIn and several other places, is to use an app called Restream to do this. However, they decided to discontinue allowing this starting tomorrow. And since I don't want to use Facebook Live to just stream to the group and nowhere else, you will have to catch me on one of the other areas where I stream, including this YouTube channel. It's at SPM Long COVID on YouTube. And you can also find pretty much all of the social media where I stream on covidinstitute.org. That's all. I just wanted to say these last couple of things. And let me see here. How can I stop this now? And I'll just leave this up. And let's go back. Let's go back to our questions. Let's see where we are. Here's a question, and I will talk about the chart breakdown, but I don't know if I could do it in the Muppet version out here. But I'll do my best. So let's talk about the question about the Sonamia. Is it treatable or do you just have to manage it? Well, before long COVID came along, the Sonamia still existed. It was more associated with POTS. And POTS is postural orthostatic tachycardia syndrome, and the cardinal symptoms of it are tachycardia, which is fast heartbeat when you're standing or when you're upright. And the orthostasis part is either feeling dizzy or feeling like you're going to pass out or actually passing out when you're standing up. That's the majority of the dysautonomia we saw. There's another big dysautonomia that people don't think about, and it's vasovagal syncope or cardio vagal cardiogenic syncope, which is passing out because of a slow heart rate, and that's an overreaction on the vagus nerve. That is also a type of dysautonomia. But those two are kind of the most common type, and we're seeing more than just POTS with long COVID. I think it's more advanced, more expanded. And what's interesting about dysautonomia is it does not need to involve the entire autonomic nervous system. It could only involve a segment of it, and that can present in various different ways depending on which segment is involved. So in the past, the way you would manage it, not treat it, well, actually, I could say it's treated too, but just not cure it, is by treating the symptoms. So, and the way that you would do that with POTS is by increasing your salt intake, increasing your fluids, taking medications that would slow your heart rate down, such as a beta blocker or calcium channel inhibitor, or something like Corlinor. That would slow down your heart, and something to increase your blood pressure, such as Midodrine, and something that would help you retain more salt and fluid in your circulation, like fludrocortisone. Those are kind of the mainstay treatment of POTS in general. But it doesn't cure it, because if you stop those medications or those actions, the symptoms come back. Our goal is obviously to treat it so that you don't need to take any of these medications after treatment. Somebody is asking from Facebook about side effects or complications after EAT, which again is epipharyngeal abrasive therapy. So in any case, the way I look at it, it's kind of like a trigger point for your throat, or the back of your throat, and you can have some bleeding or a soreness there after treatment, but that's really it. I mean, there's not a lot of side effects or complications post treatment. Our next question from a Facebook user: how does EAT help long COVID, and would interact with SGB and help improve efficacy of each other? So yeah, that is something that I proposed after reviewing how EAT works. So it doesn't necessarily have to be done in somebody with a sore throat. Okay, that's important, or just postnasal drip. So every single long COVID patient that was tested in Japan during that study showed some amount of epipharyngitis. Okay, even if you don't feel it, it's there. So the way I think it's going to work in combination with a stellate ganglion procedure is that both attenuate the fight-flight response in different ways, but they'll work together to potentially create a cure. Now we won't know this until a few tries, but in my feeling that this is going to be a great combination for the treatment of long COVID as well as chronic fatigue syndrome, by reducing these inflammatory markers that are being produced. Okay. Hi, Carrie. So, best vitamin supplements to help with mitochondria. Well, this is a loaded question. There's more than 30 supplements, vitamins that are used, including some peptides. So it kind of depends on what part of the mitochondria is broken or not working. And mitochondria do more than just energy generation. They also help us break molecules down, okay, especially the carbon single carbon molecules, and are also involved in manufacture. So without knowing exactly what's wrong, it's hard to really recommend a list for you. But in general, antioxidants work well, okay? And the three that I like in particular are resveratrol and curcumin and quercetin. I like those three because they have a bunch of neat little features, and they also help the mitochondria as well. Okay. If you're looking for vitamins, a lot of the B vitamins are useful for mitochondria. Okay, because most of them are involved in the catalytic process of either activation or methylation. Okay. So whether or not you have the MTHFR gene or not, they're still important for mitochondrial function, as well as magnesium. Okay. Let's see here. Alexander is asking about anosmia, post-double stellate ganglion procedure, and oxytocin nasal spray. So I take it that the anosmia is still there. So as I said, the longer the smell and taste issues are remaining, the longer, the more resistant it becomes to treatment. But there are still some thoughts and um, some ideas. One is the insulin treatment, the nasal nebulization, not oral. Okay, this is not meant for insulin to be taken into your lungs. Okay, it's meant to kind of bathe the area of the nasal cavity. Okay, so there's also theophylline. I don't think that these are particularly highly successful treatments, but they are something to at least consider if nothing else has worked. And if I can ask you guys to keep the conversation in on this thread related to questions only, not to do side chats and side conversations, because it's a little distracting, and I want to be able to answer as many questions as I can. Okay, thanks a lot. Let me see here. What will be the next question? Mandy, I have had long COVID for 3.5 years. I'm sorry to hear that. The migraines and sensory overload are debilitating. Any advice to help with this? I've tried all the migraine meds on the market, pills, injections, and nerve blocks. Okay, I'm assuming you're not calling it a stellar block. I'm assuming you're referring to the stellar ganglion block, right? Okay. So I would start with basically a good history and an exam, and to make sure that it's an actual migraine, and to see if you've had similar symptoms before COVID, or is this new symptoms since COVID? And I would do an exam, and I would see where where the headache starts, how long you have the headache when it happens. Have you tried prophylactic medications as well, or just basically what they call abortive medications that stop a migraine? And it's always more difficult to stop a migraine than it is to prevent one. And I may consider doing a brain MRI if nothing has helped, and if I still suspect it to be a migraine, nothing else. Okay, because we want to make sure that there's no other process going on that could be inciting the migraine. I would look at triggers. I mean, there's quite a bit involved um, to manage a migraine. There's no cure per se, but there's definitely effective treatments, and it just comes down to figuring out what's causing it and what works the best. Okay. Tinnitus. Oh, that's a good one. That's a good one, Lee. There's several different causes of tinnitus. Okay. The kind of tinnitus that I tend to treat are the ones that are associated with long COVID or dysautonomia. What I found is that the other cause, which is from hearing loss or hearing damage, I've mentioned this a few times in past broadcasts, but basically anything that caused either acute or chronic hearing damage, such as loud concerts, explosions, working around jet engines, basically anything where you're exposed to noise beyond what your ears are capable of dealing with, either on a short-term or long-term basis, can cause damage to the inner ear, and that could result in tinnitus. There are other causes of tinnitus, such as pulsatile, which would be similar to hearing a heartbeat. Those are usually caused by a blood vessel being very close to the inner ear, and those are not treatable medically. That could be potentially treated surgically. But the kind we're talking about is a tone or constant tone that you may sometimes lose. If you're busy or not paying attention, you may not be hearing it, but it's always present. And of course, it's louder at night or when it's quiet. So what I found is the vagus nerve stimulation and the stellate ganglion procedure to be the top two. Tinnitus. I just recently actually posted a study from 1969 on the Facebook group that I run, where you guys are. Well, some of you guys are. That looks at multiple stellate ganglion procedures to treat this. So even that early, they've recognized that some forms of tinnitus are amenable to treating with this procedure, because it is based on dysautonomia. It's irritation of these nerves, and it presents itself as a tone or as a sound or as a buzz. On the skin, it can present itself as pain or tingling or pins and needles or feeling like ants are crawling. But in the ear, it presents as a tone. I hope that answers your question, Lee. I am asking in the group to get connected with docs in the UK and other countries who I can work with, but I haven't established a relationship yet with anyone who I'm working with right now. But yes, that's the goal. The goal would be to establish relationships with like-minded doctors and individuals who want to treat long COVID and get people better. Hi, Rachel. So, what cohort do nicotine patches work best in? Well, there was only one study really done to look at it, so we don't know the full type of cohort that it can help. But there are multiple ways that nicotine does help, and one of the most important mechanisms, I believe, is by restoring the ACE2 receptors back on the surface of cells. So some cells have a lot of these receptors, and when COVID rolls around or spike protein rolls around and attaches itself to these receptors, the entire complex gets engulfed into the cell, and the ACE2 receptor does not get recycled back to the surface. So what nicotine does is it causes the transcription of the ACE2 receptor to be produced. And you basically are generating more ACE2 receptors. And once they're translated into a protein, they get displayed on the cell surface again. So we know that ACE2 does play an important role in long COVID. So that is, from my standpoint, that is the most important way that the patches work. There is some dysautonomia help it does by activating certain autonomic nervous system receptors, but I believe that the main role would be the reactivation of the ACE2 receptors. Hi, Dustin. So when we're talking about TENS, myalgia is a pain in your muscle. It's non-specific. It has many different causes. And I'm not sure if you're talking about using the TENS unit in the way that I use it as a vagus nerve stimulator, or if you're talking about in the traditional sense by putting two pads around a muscle that hurts and stimulating it that way. So there's this. If you're talking about the latter, um, there's no time limit. I mean, you can use it as often as you need to, and as often as you want to stimulate the little nerve endings in the muscle to help. If you're talking about vagus nerve stimulation, I don't recommend doing it for longer than 30 minutes at a time and no more than twice a day. And typically, I see results in as early as 30 days, but and as late as 90 days. But in general, if you've been using it for 90 days and you haven't seen a result, I usually recommend what I call tweaks, and that would be started as early as 30 days. And the tweaks would be something like changing the lead position on the ear and switching ears. And again, if you're using it on the right ear, I recommend checking your heart rate to ensure that you're not developing bradycardia. Changing the frequency between anywhere from 15 to 30 is acceptable once a day. And that's just sometimes the vagus nerve will get used to the same frequency over and over again. So the idea there is to kind of keep it guessing and to continually be able to stimulate it. Okay. There's some other tweaks I have in my files, but those are the main ones. Okay. Okay, Ree. You have bradycardia. Heart goes into 30s and 40s at night, and sometimes that's normal. Some people do have quite a bit of bradycardia at night. We all are supposed to have a heart rate decrease at night during sleep, especially during deep sleep. Um, so you believe that the current shortness of breath, fatigue can be related to bradycardia? Well, yes. I mean, bradycardia can certainly cause shortness of breath, but I don't know if you're experiencing that um, only at night. Looks like you're also experiencing during the day. So with bradycardia that low, I would do an evaluation with a cardiologist and start with an EKG and go from there. Um, this is not something that you should be managing on your own. Okay, that's something you should work with your cardiologist, or if you don't have a cardiologist, I would find one. Okay. Facebook user is asking if nicotine really helped with symptoms. Yes, it does. For some people, it's kind of a miraculous recovery. Not everybody, though, maintains it after stopping the nicotine. So if the symptoms recur after you stop, then there's something else going on besides just the ACE2 receptors. There's going to be something else. Okay. And most often it's going to be the Sonamia. I mean, you could have the mitochondrial issues, but something else is driving it besides just lack of ACE2 receptors. Facebook user is asking about basically having kind of a withdrawal effect after stopping vagus nerve stimulation and getting high heart rate post using a vagus nerve stimulator. That's not something I've seen in my experience, so I'm not quite sure what's going on with you specifically. Um, it may be useful to get a stellar ganglion procedure. I don't know. If you're interested, you're welcome to call my office, and we can certainly discuss it and see if you would be a good candidate or not. Facebook user is asking about chronic fatigue syndrome after COVID, after for 2 years to go away by itself. Typically, the symptoms that I've seen go away by themselves, if they were going to go away by themselves, is basically anosmia, maybe parosmia at around a 2-year mark. The chronic fatigue that develops from long COVID is very similar to the chronic fatigue of chronic fatigue syndrome. It's a post-viral syndrome and typically does not go away on its own. You have to do something about it. Sorry to tell you that, but that's just what I've seen in my experience. You have to treat it. You have to treat it. Okay. I'm not sure which Facebook questions you're talking about, but I see your video. I see your question about this time. It's just I can't answer every single question. I'm trying, but it's just me. I don't have a producer or anybody to basically go through and ask these questions. So I'm going through them one at a time, and I may miss a question or two. It's not your fault. It's not my fault. It's just sometimes I do. Sorry. That's a great question about correlation with antigens and symptoms in the study. And no, if you actually look at the study, there was no look. They did not look at symptoms at all. And that's kind of why I'm saying that just finding those antigens does not mean they're responsible for long COVID. It just may be the way COVID-19 works, or it may take a long time for our bodies to clear all the antigens. But it does not mean that it's causing long COVID. In fact, they even mentioned this in the study, saying that this is something that needs to be looked at as far as causing symptoms. But they did not make that correlation even. Marion is asking, what treatments have you seen that help with CFS? My neurologist has recommended I try amantadine. Amantadine is kind of an interesting medication. It's an anti-dopaminergic. Okay, it's also used in flu. It helps prevent um, influenza A from multiplying. It's kind of an interesting medication, and it has been shown to be used with chronic fatigue syndrome. While many of the therapies kind of commingle between actual chronic fatigue syndrome that one developed 10 years ago, 15 years ago, and the current one where people are getting chronic fatigue syndrome from long COVID. I find that a lot of the treatments from the original chronic fatigue syndrome work in long COVID. I mean, that's kind of where long COVID, a low dose naltrexone therapy came from. It wasn't out of thin air. It was because it was being used in chronic fatigue syndrome. And it showed some efficacy for some, not everybody, for some, during long COVID chronic fatigue syndrome. So without knowing if you have the original kind or the new kind, but they're still relatively similar in the way we treat them. So one of the new treatments that I'm going to be offering for chronic fatigue syndrome, and that includes the ones that even people have had for pre-COVID, will be this EAT therapy, which is the epipharyngeal abrasive therapy. There's been one case report and one study showing its effectiveness in chronic fatigue syndrome. That doesn't mean that it's going to help every single patient who has chronic fatigue syndrome, but it's another tool that we have that wasn't available before. Are there any other treatments for chronic inflammation in the nasopharynx for people who can't travel that far for the EAT? Well, I mean, you can always go to Japan. I mean, that's kind of where it originated from. And this treatment is something that they use for their regular visits. So basically, you come in for a wellness checkup, you get one of these, and you come in for a follow-up, you get one of these. They've been doing this in one form or another since the 1960s. I do not recommend you do this on your own, okay? Please don't shove things down the back of your nose on your own, okay? You can do some damage, and unfortunately, there's nothing else that I could think of that would take place of this. And my goal is to combine these treatments, basically the EAT and the stellate ganglion procedure together, to eradicate the dysautonomia. That's my goal, okay? Great question. What long COVID symptoms have you successfully treated with SGB? So pretty much everything you can think of. Most of them are going to be the bread and butter symptoms that respond well are going to be the neurologic and the psychiatric or psychological ones. So the big ones would be things like fatigue, the brain fog, the anxiety, Okay, and of course the anosmia and the parosmia. Have I seen neuropathies go away? Yes, I have, and I've seen tinnitus go away in people who've developed tinnitus from long COVID. And there's many other symptoms such as chest tightness, chest pain, shortness of breath. I had people who had resolved. The coat hanger pain is a big one, where the pain basically is in the head and the shoulders, kind of looks like a coat hanger. So it's called the coat hanger syndrome. In some people, headaches have gone away, but what I found is that pressure headaches have not, and that's where I think this EAT therapy is going to be very useful, to basically be complementary or synergistic with this daily ganglion procedure. Okay, there are many other symptoms that resolved, including things like rashes and diarrhea. But those are not the things that I typically look for, but have been reported. Okay. So the mechanism behind low dose naltrexone is that it's basically an anti-inflammatory for the support cells of the central nervous system. So basically, nerves that are in the spinal cord and in the brain tend to respond to low dose naltrexone. Okay, that's typically the main mechanism. It does have some pain relieving properties. Okay, it's a paradoxical reaction because normally, if it was a high dose naltrexone, it would actually reverse um, endorphins from binding to the mu receptors, which are the main opioid receptors responsible for pain relief. But at low dose, it does something different. Okay. My goal with the treatments is to be able to reduce the number of them because, unlike the docs in Japan who do them once a week, my goal here is to combine them with the stellate ganglion procedure. And with the synergistic effect of the dysautonomia resolution, I don't think people are going to need that many treatments. Okay. In regards to anything I do in person, there's kind of no other way for me to administer treatments. So if you want to get the stellate ganglion procedure for me, you have to travel to the US. And if you want to get the EAT procedure for me, you have to travel to the US. And if you want to get them both, you have to travel to the US. I don't have a satellite office yet in the UK, maybe in the future, but first things first, I'd need to get licensed in the UK, and I haven't really gotten any guidance on that yet. Creatine kinase or creatine monohydrate, um, it is a mitochondrial supplement. So if your issue is caused by mitochondrial dysfunction, and some people, the fatigue and the brain fog are. We have seen that in chronic fatigue syndrome. Some people have a mitochondrial dysfunction. So in those cases, yes, it would be helpful. If I missed your question, you can go ahead and repost it. And it's kind of hard for me to go back um, and find it. I apologize. But if I didn't answer your question, feel free to repost it. Okay. So let's see. So even though EAT has been available since the 1960s, I haven't met any ENTs that actually perform it here in the US or really anywhere outside of Japan. I mean, you're more than welcome to talk to an ENT about it. Um, but unless they understand why we're doing it and the reason we're doing it, they're not likely to want to do it. Um, I mean, if you're really persuasive and you can get them to do it, more power to you. Um, but it really hasn't taken off in the U.S. or really any other country except the Asian countries, especially Japan. Okay. So sensitivity to supplements. So what exactly does that mean? Are we talking about like vomiting afterwards, having a stomach ache afterwards, getting sick afterwards? You have to be more specific in what does it mean that you're sensitive. You take smallest amount of dose, and how do you react poorly to them? And if this is new, this may be a manifestation of histamine or Mcast or some form of allergy. It's kind of hard to know without doing tests and getting more history. So, hyperbaric oxygen therapy does have its uses, for sure. It is a medical treatment, and things like carbon monoxide poisoning, bends, unhealing ulcers, all those have been used with hyperbaric oxygen. There is a study or two out showing some effectiveness with brain fog and or fatigue resolution post hyperbaric oxygen therapy that's actually lasting. However, for this, basically for this indication, if you're treating long COVID, it's going to be out of pocket, which means insurance is not going to cover it. It is relatively expensive, and you're going to need many treatments to accomplish this goal. Some people have adverse reactions to high concentration and high pressure of oxygen, though. So keep that in mind. It can make tinnitus worse. It can cause other problems for some people. Okay, that's pretty much all I would treat with hyperbaric oxygen therapy, though. I'm also not a huge fan of oxidative based treatments because in long COVID, we already have a huge oxidative stress load on us from the chronic inflammatory condition and state. And we don't produce enough antioxidants on our own to combat that, which causes issues with the mitochondria, which makes them not function well or basically have them shut down. So, presenting your body with another oxidation event, such as hyperbaric oxygen, may not be the wisest move. However, I do understand that there is some utility to it. I mean, there's a study showing it works for some with those two symptoms. Okay, so you need to decide if it's something that's worth the risk for yourself or not. Okay. I don't know yet, Marian, how many treatments are going to be required. It depends on how long the person would stay, but I don't think we'll need the same number of treatments that the study proposes because I'm going to be combining with the stellate ganglion procedure. Related to the Lancet antigen finding, what do you think about broad-spectrum antivirals or supplements that have antiviral properties? I have not really tried antivirals or broad-spectrum antibiotics or anything like that because there's a risk to those. The number one risk is basically decimating your microbiome in your gut. Being on long-term broad-spectrum antivirals can cause mutations in other viruses that may live on you or around you. They may not normally be causing a problem, but could mutate as a result of being subjected to long-term antiviral therapy. So we still don't know what the implications of antigen presence, and we also know that it declines with time. That's what the study also showed, that both the spike antigen and the nucleocapsid antigen declined with time. Okay, so I'm not sure if we actually need to do something about it or not, or that's something that's going to go away on its own. And we haven't made the correlation yet, or causation, more importantly, between the antigen and long COVID. So no, I wouldn't be trying this right now. Who knows what the future holds? If we find out that it is the cause, perhaps. How do I treat insomnia? Oh boy. I did actually 2 videos on this that I'll try to post. They're both on YouTube. You have my channel, right? The YouTube channel that I posted. But I did 2 videos on this. I treat the cause. I don't just sedate. I treat the cause. You treat the cause, the insomnia goes away. Okay. I don't want to take the time right now to find the videos for you, but they're on the at SPM Long COVID on YouTube. There's 2 of them. Okay. Best supplement for hypothyroidism and low estrogen. Well, first is, are you symptomatic? I mean, the issue is did you just do a test or are you symptomatic for these? And the best supplement is to replace the thyroid hormone, replace estrogen. I mean, I know it sounds kind of simple, but we're talking about bioidentical replacement. For thyroid, I usually recommend going with something that's like a desiccated thyroid versus some of the synthetics, which I'm not going to mention, but there's 2 synthetics that are available. I prefer to use the natural desiccated compounds for those. And for estrogen, like I said, replacing estrogen. But only if they're causing a problem. And with estrogen, I don't usually mess with it in somebody who's currently still getting periods. So that's just my own approach to it. Okay. Okay. Again, when the study was done on EAT and long COVID, what they were looking at was just EAT. They don't combine it with anything else. I'm going to be combining it with a stellate ganglion procedure, and I expect different results. I don't think it's going to be necessary to do it as often or as frequently. But we will see how the interaction works. Roland is asking about adrenal dumps, dry heaving. So adrenal dumps are not related to dry heaving. Adrenal dumps, are we talking about basically a dump of adrenaline into your bloodstream, right? Um, as part of dysautonomia, as part of POTS. So when you have an acute episode of fight flight, it would cause fear and anxiety, and that can often cause nausea. Um, as many who have gotten up in front of a stage to talk about a large audience, but have stage fright, have experienced, or performance, right? That's basically an adrenal dump. So I'm not really sure what the question is. I mean, the the treatment is to treat the dysautonomia. Yes, I find a lot of patients with internal tremors or buzzing, vibrations. It's been referred to many different things. Sometimes it's in the chest, sometimes it's in the stomach, sometimes it's other places in the body, Heather. And I believe this is a form of either neuropathy or how anxiety manifests itself from the dysautonomia. It is real. It does occur. I've had multiple patients with this, and it resolves when you treat dysautonomia. Okay? I have seen, Linda, I've seen patients develop just about every psychological and psychiatric condition you could think of. Everything from depression to anxiety to PTSD, different kinds of depression, including bipolar, derealization, depersonalization. I mean, you name it. It's a result of the severe insult that's causing your body trauma, basically. This can develop from either chronic or severe physical trauma, or it could be from mental trauma. And you're kind of getting it from both ends on long COVID, okay? Lisa, I'm not really sure where the question is here, but I will address this as a cancer. In general, I think the incidence of cancer has increased in people with long COVID. Um, I don't think it's necessarily limited to breast cancer, but certain cancers do tend to occur or have seemed to have occur more frequently in people with long COVID. Mandy, the best response I have for you is why don't you schedule an office visit with me or a consult with me, and we can go over everything you've tried and did, and I'll tell you my ideas, okay? Because I have quite a few of them, but it really depends on all the details, and without knowing all that, I can't really answer you, and I can't answer it here in a public forum anyway. Lisa again. So I don't really treat mycotoxins. That's something usually limited to functional medicine doctors. If you're not getting any relief after your treatment, feel free to call my office and I'll be happy to help you. I have my own protocols and ways of addressing long COVID. And if you're already doing the treatment, as you say you are, go ahead and complete the treatment and give me a call whenever, if you still need assistance, okay? I know there's a very popular group on YouTube. I'm a member as well. I'm not going to mention their name, but they kind of it's more of a lay person trial, so to speak, and their treatment tends to be almost infinite. There's a long time to be on the patch, and no amount of time is dangerous and stuff. But I personally prefer to limit it to 30 days. I don't think there's much benefit to using it for more than 30 days. I actually limit it to 2 weeks. It doesn't take much to get the ACE2 receptors back to working. Okay, the goal here is not to establish dependence on nicotine. Okay, and yes, you will develop dependence on nicotine because it is addictive, but we're not talking about addiction here. We're talking about dependence. That is, your body becomes used to it and wants it, and you will have withdrawals after you stop it. So that's not addiction. Addiction is craving something for no reason whatsoever except for the craving aspect of it. So I recommend limiting it to 2 weeks. If there's no improvement, then you're done. If there is an improvement, you can continue it for another 2 weeks, and then you're done. 30 days max. I'm balancing risk versus benefit here. I don't think there's really any benefit in continuing nicotine for months at a time, as I've seen people do, or years at a time, as I've seen people do. If you only feel better while on nicotine, then it kind of defeats the point. The idea from my brain is you use it to treat the condition and you stop it. And the condition here is the ACE2 receptor replacement. And that is it. Okay? Hi, Lisa. um, I would really, you really want to limit one treatment at a time because it's going to be interactions. Typically, what I found is sensitivity to light, sound, smells, things like that are mostly associated with chronic fatigue syndrome. And obviously, there's ways to treat that, but you don't want to combine multiple treatments and do basically the kitchen sink approach. If you're, and I'm assuming it's a functional medicine doctor because that's the only ones I see doing the mycotoxin treatments. If you want to finish your mold treatment or you want to continue it, go ahead. I don't do those. If you feel better, great, then you're done. Report back. Tell us how well you did. If you're still having symptoms and not feeling better, then give me a call. Like I said, there's plenty of things I can do, but I can't do it on here. Shortness of breath. Okay. Tachycardia. Both doctor and rheumatologist are waiting to wait 3 months before saying I have long COVID. I have previous autoimmune diseases. Sure, that makes it more complicated. Okay. When you have pre-existing autoimmune conditions, it puts you at also higher risk of developing long COVID. It doesn't mean that you will, but it just definitely puts you at higher risk. And it definitely muddies the water because then you don't know if it's your autoimmune diseases causing the problems or if it's the long COVID. Shortness of breath and tachycardia. First, look at the Sonamia. That's the most likely culprit. 99.9% of people I treat have dysautonomia in one form or another. Okay, whether it's evident and obvious or if it's a little bit more hidden, it's there. It is there. The second thing, at least for the shortness of breath, you could look at is mitochondrial dysfunction, but it's more likely than not going to be dysautonomia. Okay, if you've had COVID and you develop symptoms that are representative of long COVID, guess what? You have long COVID. Could it make your autoimmune conditions flare up? Absolutely. I don't know which ones they are, But if your symptoms transcend the autoimmune conditions, for instance, if you had ulcerative colitis, if it transcends the colon, and if you have rheumatoid arthritis and transcends your joints, um, chances are you have long COVID. My thoughts are it's not necessary, Lisa. It's not necessary to wait 3 months, just because the definition goes along 3 months. I mean, if I ran over your foot with my car, you don't need to wait 3 months for me to tell you that I ran over your foot. It's sometimes pretty obvious, even if it's confused by other conditions. If you've been treating it as long as I have, you kind of know whether it is or it's not. It's 100% clinical diagnosis. I mean, there's no labs to really confirm if you have long COVID. There are some markers that can suggest it, though. One is looking at AM cortisol levels. If your AM cortisol level, and that's usually on before 9 a.m., or evening cortisol level is low, that's suggestive of long COVID. It's supposed to have a 96% predictive property to it. Another is to look at Epstein-Barr reactivation, CMV reactivation, and other herpes viruses. If they reactivate, again, it suggests having long COVID. But unfortunately, there's no specific test that if it tests positive, it says you have it, okay? If nicotine makes you dizzy, well, nicotine makes you dizzy. That's what it does. It's a stimulant. It's a neurostimulant. It's also a sympathetic nervous system stimulant, which is why I don't suggest using something like this for months at a time, for years at a time. If it makes you dizzy, cut the dose or stop it. I mean, you're having a direct result of nicotine stimulation. That's what it does. Are there any recommended therapies for different durations of long COVID? The earlier you treat it, the more successful you're going to be. Okay, that's what I found. This is from more than 3.5 years. I mean, we're approaching 4 years of treating it every day. This is kind of what I'm seeing. The earlier you treat it, the better. Recommended therapies: treat the dysautonomia. I'm going to keep coming back to this. Treat the dysautonomia. This is at the core of long COVID. Okay. All the other things that occur are from the dysautonomia. Occasionally, there's some straggling symptoms that may be from mitochondrial dysfunction, where they got dysbiosis, but it comes back to dysautonomia. It's stubborn. It doesn't want to go away sometimes, but it's there. Possible for heart aches like fire or knives. Are we talking about reflux, like heartburn? Or are we talking about like chest pain that's different from heartburn? So I've seen heartburn and I've seen chest pain in long COVID. So without knowing more, it's kind of hard to know if you developed reflux, something that's, for instance, associated with position. It's worse when you're laying down versus when you're standing up, or it's worse after meals, suggests more heartburn. If it's associated with chest tightness, it could be related to myalgias. It could be costochondritis. It may be neuropathic. It needs to be determined which of these causes. And of course, just because it's long COVID doesn't mean that you don't have to rule out the bad things. Okay, like you said, heartaches. you need to check your heart. You need to check your lungs. Just because you have long COVID does not mean that you can't develop angina, that you can't develop shortness of breath for other reasons. Okay, so these things still need to be ruled out before just assuming everything is long COVID. All right. I'm going to wrap things up right around 4:30, okay? And that would be an hour and a half for today. Now, as a reminder for those who joined us after I said this, Meta or Facebook, the owners of Facebook, have decided that they will no longer allow third-party streaming into groups. Even though I manage the group, even though I started the group, doesn't matter. They won't allow third-party streaming into the group. So that starts tomorrow. So basically, you will have to use one of the other streaming sites that I post to, or social media that I post to. All of them are listed on covidinstitute.org. Covidinstitute.org. It's one word. And they're listed on the top and bottom in the header and footer. And you can find the YouTube channel there. You can find the LinkedIn channel there. You can find the Twitter channel there. Basically, you can even go on the Facebook page that I have that's under my name. But I won't be able to basically send a stream into the group. I know some of you are going to say, well, why don't you just do Facebook Live? Well, I would, except then I won't be able to stream it into YouTube, into Twitter, into LinkedIn, into Instagram, into the other channels that I run. And I'm trying to get my message out to as many people as possible. And I also have a problem with Facebook basically creating this kind of censorship. So I just won't stream into the group that way. So you won't be able to see this inside the group except as a replay. I mean, I can post it as a replay, but I just won't be able to stream it live. So that's just something to keep in mind, okay? So there's plenty of places to watch it. There's plenty of places to interact with me. It just won't be inside the group during these streams. And that's going to be starting tomorrow. Yeah. That's Meta's infinite wisdom. I work here. All right. Why don't we get back to the questions? Let's see here. A few more came in while I was jibber jabbering. Hi, Lisa. There's a lot of different tests that I recommend. There's a core that I rely on, but I add my own specific ones depending on what I'm looking for. Okay, I don't just order a huge panel of tests and kind of see what, throw it at the fan and see what sticks to the wall. There's actually some thought behind it. And everything I order has a significant meaning for me, whether it's positive or negative. So I don't really recommend much imaging to begin with, unless we're suspecting something like lung problems, where I want to look at maybe a CAT scan of the lungs, or if there's suspicion of some brain issue where we want to get a brain MRI, for instance. But for the most part, I stick to blood and urine to determine where to go next. And mainly what I'm doing with these tests is not to diagnose long COVID. What I'm looking for is to rule out other things, okay, other causes, other problems. So I may look at ANA, or I may look at CRP or ESR. I'm looking for other issues going on besides long COVID, because guess what? All these things can still occur during long COVID. We just have stopped looking for them because everything is focused on long COVID. And I may order some tests, like if I suspect mitochondrial or histamine problems or Mcast, but most of those are still diagnosed clinically. Okay, there's nothing you need to do beforehand, but treatment with me though, if I'm suspecting something, and I would order some labs, but they're not absolutely necessary to order before starting treatment. Okay, you're having a procedure in Pensacola. EAT is a preferential EAT therapy that's not really being offered in the United States. It's really mainly a Japanese procedure. I am bringing it to the United States, and I'm going to be offering it together. That's not something that your pain doc is going to do for you. Okay, just so you know. Did we do this one? Sorry, I'm a little behind. Highly, yes. Especially if you're having postnasal drip, especially if you're having coughing, chronic cough, or mucus, yes, this will help you. That's one of the main reasons they use it. They figured out that it has kind of an interesting side effect in helping with the Sonamia as well. So yes, it would help you. However, for this, you may need to do it more than once. This treatment just has not caught on outside of Japan or outside of the Asian countries, even though it's been around since the 1960s. I would have to say that I guess some of the ENTs don't believe in it or don't think it can help, despite some of the evidence. Mandy is asking about red light therapy for inflammation. I think mainly the infrared or near infrared is helpful for inflammation, but keep in mind that the penetration is very limited through the skin. So it helps with pain for sure. I mean, there's plenty of studies for that. It's not going to charge up your mitochondria or anything else. I mean, there's a lot of weird papers out there, but I think for inflammation, I would do either near infrared or infrared, which is basically heat. It's radiant heat, but it's still heat. That's how we feel it since we can't see it. So yeah, I mean, I think it's perfectly fine as long as your expectations are realistic. Adnan is asking about SGBU sulfur body dysfunction. Yes, I think that's one of the other mechanisms that is corrected, because I've seen a lot of people, their POTS symptoms either resolve or significantly improve post-treatment. So somebody posted a study in our Facebook group about carotid body having a lot of ACE2 receptors. So we know they get affected or infected initially, and there could be some initial damage going on there. But yes, I think that is one of the mechanisms that the stellate ganglion procedure does work. And I will do one more question. I'm trying to find that last question that I can answer well for you guys. This is not going to be the last question, but if you want to schedule an appointment, it's on covidinstitute.org. You basically go on there and go on to contact us, and there's instructions of how to contact me or how to set up an appointment. Yes, we're in Texas. All right, let me answer this question because it's kind of a unique question, and that's going to be it for today. I apologize. Save it for next time. And just a reminder again, we're not going to be live streaming directly to this group, to the Facebook group, to the COVID Institute Facebook group, because Facebook has decided not to allow that. You will have to go either on the YouTube or the Twitter channel, my channel, or LinkedIn or Instagram to comment or ask questions there. I don't know how well it's going to work yet, but I will do my best to give you the links and everything, although they're, again, on covidinstitute.org. 90% success rate with SGB. Yeah, that's true. Do you believe some of the unsuccessful ones have Lyme, co-infections, EBV, and do you treat these other conditions? Yes, I do. If I believe that the reactivation of EBV or one of the other co-infections is causing a problem, I treat the problem. Yeah. I mean, that's pretty much what you do. You put it back into latency, and then you focus more on the dysautonomia again. Anytime you have something basically preventing the dysautonomia from disappearing, and that may be part of the resistance. And of course, if you have something that caused the dysautonomia in the first place, like Epstein-Barr virus or CMV infection, Lyme is a little tricky. So I'll address that at a different time. But yes, some people have untreated Lyme. But yes, so those are continually destroying your autonomic nervous system. Not just destroyed it once, but are damaging it continuously when they reactivate. We know that. I mean, that's what they do. And if they're causing damage now, it's going to be so much harder to stop the dysautonomia in its tracks. If you have some active process, this is one of the reasons why I want to do this EAT, this epipharyngeal abrasive therapy, because a lot of the stuff that's basically not causing but continuing the dysautonomia, I believe, is in there. And a little bit of work there may quiet everything down and let the dysautonomia finally end. And that's what I'm hoping. Okay. Thank you so much, guys. As I said, this is my last question, and I'll post sometime tomorrow all the links again. You can find them all on COVID Institute. I made it pretty simple to follow me pretty much on any social media. I'm pretty much on everything except for TikTok. And that's mainly because they suppress any long COVID discussions or talk, or COVID talk and discussion. They basically just wipe the videos or remove the videos. But I am on Instagram under COVID Institute. I am on Twitter under, sorry. I'm on Twitter under COVID Institute. I'm on Facebook under COVID Institute, as you know. I have a page on Facebook. It's Robert Groysman, MD. And all those will stream. I have a LinkedIn, COVID Institute. Okay. I mean, pretty much every other media that I could think of, except for TikTok. And of course, YouTube is under COVID Institute. Yes, you guessed it. So you can always find me under COVID Institute, pretty much any social media. And unfortunately, we won't be able to live stream into the Facebook group anymore, COVID Institute Facebook group. But that's not because I don't want to, but because Facebook decided to put a ban on it starting tomorrow. Okay? Anyway, take it easy, and I'll see you in 2 weeks, and we'll see how that works. The next time is going to be at 10 a.m. and on a Sunday. Okay? Bye-bye.